same patient, we'll continue. So the patient was evaluated, and you know that he has the severe LUTS as per the IPSS, prostate measuring 60 cc, no other comorbidities, quite young, fit, sexually active, 48-year-old. So what is your next step? The investigations like urodynamics proved presence of obstruction, but otherwise flow rate showed a obstructive voiding pattern. Post-void residue is 130 ml, and is quite symptomatic. What is your next step?
So this is a young patient who is severely symptomatic, and so the next option would be starting him on medical treatment. He has tried conservative and that didn't work. So I'll start this patient on alpha blockers and assess his response in 3 months' time with a repeat IPSS, post-void residual, and uroflowmetry, and then see his response to the alpha blocker medication. And then in the next step, then I can consider adding the 5-sulfuretase inhibitors. Meanwhile, I will also discuss starting both medication at one time as well with the patient. But in my practice, I will start him on alpha blockers.
What are all the advice you will give in lifestyle changes for him?
So I will advise this patient to uh, uh, time his voiding, reduce fluid intake in the evening time, avoid caffeinated drinks, and avoid bladder irritants and avoid constipation. And these lifestyle changes would be helpful in improving his lower urinary tract symptoms.
Is there any role for phytotherapy?
There is no recommendation from EUA and ISO AUA guidelines, but they are used as several are available, but there's no recommendation, based upon studies.
Okay, so what is your drug of choice to start for this patient?
So I will start him on tamsulosin, 0.4 milligram once a day, explaining the side effects, and that would be my drug of choice for him.
Okay, so how will you explain the side effects?
So I'll tell him that there is a risk of retrograde ejaculation. He has some postural hypertension, which is in less than 10% of the patient. And it happens usually in the initial few days and it resolves. So whenever he's standing up from the lying or sitting position, he shouldn't do it suddenly. And he should take this medication initially at the night time before he goes to sleep. I'll also explain that he may have some hypertension with this medication. And other than that, if he has some eye surgery planned, then I'll need to inform his ophthalmologist for the floppy iris syndrome as well.
Okay. So between various alpha blockers, do you have anything to choice, or is there any evidence behind your choice of tamsulosin?
The usual evidence is from the studies done on alpha-leucin and doxycycline that were used previously. But alpha-1 tamsulosin is alpha-1 a selective medication, and it is more prostate selective and with limited side effects as opposed to the other medications. And I'm not exactly sure about the evidence for tamsulosin right now.
Okay. Now, which group of patients you will try a combination treatment rather than tamsulosin alone?
So, as per NICE guidelines, if the patient has moderate to severe lower urinary tract symptoms,
Any other factors make you to try combination? We can't hear you. I think we have lost him. Oh, he's in online.
Do you want me to continue, boss?
Yeah, please continue.
So your question is, what are the reasons why you will try combination therapy?
Yeah.
So there are various studies that have shown that combination therapy are superior to monotherapy, combination therapy with alpha blockers and 5-alpha reductase inhibitor. NTOP study compared doxazocin versus fenestride and combination monotherapies and combination therapy. and it showed that it was superior in reducing clinical progression of LUTS. Combat study compared Avodart, which is dutasteride, and tamsulosin. And it showed that combination therapy had better outcomes as compared to monotherapy. If the patient has symptoms of urgency or as well, then the patient can be tried with anticholinergics along with combination therapy as well. As per various studies, for example, I'm sorry, the name escapes my mind right now, but we'll let you.
Yeah, we'll come back to that.
Sorry, I'm back. Sorry.
You're back. You're back now? Okay, you can continue now.
Yeah, something happened to my internet now.
Yeah, I can see your mic is on, but somehow, anyway, it happens. Okay, so in your absence, what we have discussed is various evidences available to support the combination treatment. And for our patient, do you think you can try combination treatment?
I don't think so. We can consider it to begin with. So initially, I'll start with that's why I will start with tamsulosin only, because he's a young patient, so he would not be tolerating the sexual side effects of the combination treatment and the side effects. Yeah.
Okay, let us discuss something slightly different. A patient comes with a urinary retention. So, what kind of medications you will start? Urinary retention is a different scenario, but since we are discussing these medications for lower urinary tract symptoms, what is your choice in a patient with retention medications?
So, if someone comes with the retention, and then if it is it's confirmed it's not a high pressure retention, if we're considering TROC, then again we'll start him on alpha blocker. We usually start him on tamsulosin, but the study which we use for considering TROC in next 1 to 3 days is the L4 study, which use alfuzosin. So, but we usually use tamsulosin.
Yeah. Do you know any outcome of the Alford study? Any values, numbers?
So it improved the successful TROC to 30 to 40% in the patient who were more than 65 years of age and post-void residual less than 1 liters. These are the values that I can remember.
Okay. And any other publications you aware of regarding which patients will fare better for surgery, which patients will do with medications?
No, I'm not currently aware of that.
Which patients you will go ahead for surgery directly or quickly compared to starting medications? Any features will make you to think, okay, he may need surgery rather than going on with medications?
So the patients who had precipitated, spontaneous acute urinary retention with the large post-void residual volume and deranged renal function would be ideally fit for surgical management rather than trying medications and then go for surgery.
Okay, good. So your time is completed now. We'll stop here. And don't worry if there is any problem with the internet at any time, and somebody will jump in and fill the shoes in the meantime. But the end of the day, you should get the feel of that full 10 minutes. That's what I am trying. Okay, a good presentation. Since the first time we are starting, I'm sure things will go only better from now. And for the indications for surgery, there is a mnemonic RUSHES, RUSHES. R stands for recurrent or refractory urinary retention, U for recurrent UTI, S for bladder stone, H for hematuria, which is refractory to medications, E for elevated creatinine due to bladder outlet obstruction, S for symptoms deterioration despite maximal medical treatment. As you see, when I am sharing this recording, there will be a slide in the background, so that will be quite useful. So don't worry about taking the notes during the sessions. So just pause the slide, pause the video, and then go through the mnemonic so that you will get the theory behind in case if you are missing it. So the mnemonic is RUSHES. And You should bring phytotherapy if possible spontaneously, because sometimes it's nice to see that you are aware of phytotherapy, and there is a Cochrane review which shades that phytotherapy is not useful. So when you discuss the medications, the first thing is behavior or lifestyle modifications, then quickly say I will not go for phytotherapy due to a Cochrane review advising against it, and then go for the alpha blockers and other discussions. I mean, you can skip phytotherapy, nothing wrong in it, but if you know that phytotherapy some entity is there and it is proved to be not that successful with a Cochrane review, it's nice to bring those values. There is a good review in BJUI on 2011 on 6,000 men with medical management of LUTS. I will again put that links in the recording so that it's useful for you. Yeah, Alford study is the good study for urinary retention. It's done with alfuzosin, but in practice we tend to take tamsulosin, and that's the rationale behind removing the catheter in second or third day after starting the medications. And if the alpha blockers are continued, the chances of surgery is less. That's the outcome of that. And if untreated, the complications, everything you have discussed well. And yeah, there are lots of other studies you can discuss well. I think Ali has done a good job. The study which Ali is trying to bring, including anticholinergics in a male LUT, is TIMES study, TIMES, which stands for
Time
treatment.
and Times and Neptune 1 and 2.
Yeah, Neptune 1 and 2, yeah. And TIME stands for treatment of men with low urinary tract symptoms and overactive bladder. So yeah, it's nice to mention studies, especially in BPH and prostate cancer. Somehow they tend to ask again and again. Again, otherwise, combat study, MTOP study, Ali has brought out very well. Study which supports the finasteride is P less Proscar long-term efficacy and safety study. 5-alpha reductase inhibitors can be discussed. Other than that, I think side effects, everything you have done well. You can bring in NICE guidelines June 2015, because that is the last LUTS guidelines from NICE guidelines. But then NICE has released various small medical technology related guidelines for all the small surgeries or minimally invasive treatments, which possibly we'll discuss in the next scenario. So for LUTS, it is June 2015, almost going to be 10 years, quite outdated. And the one other thing is there is a BOWS information leaflet on LUTS. So it's nice to bring in the BOWS information leaflet. At least you should know that there is a leaflet available. We know the leaflet's available for a lot of procedures, but for male LUTS, we have leaflet available just for the male LUTS alone, so that patient is aware of what they are undergoing. Good. Time to go for the next scenario. We have
Sorry,
only...
one last question. Is there any trial for this indication for surgery?
No, the indications for surgery, again you can mention the NICE guidelines itself, because it is in the NICE guidelines June 2015, which is mentioned like prostate more than 30 cc, patients with increased residual urine, patients not tolerating the medicines, and patients has no improvement after starting the medicines, all those things. So it's in the NICE June 2015 guidelines. The other thing is, when you are mentioning tamsulosin, try to say it as 400 micrograms rather than 0.4 milligram, because there is a good article to say that these kind of prescription errors can happen if you are putting 0.4 milligram. Somebody may not recognize zero. Of course, tamsulosin comes in only one dose, but it's always nice to have 400 milligram as a good habit. Sometimes if the examiner is very passionate about it, they won't reduce the mark or anything, but it's a good habit even for the life and future. Okay.
Boss, can I just ask a quick question? You asked about when can this patient have combination therapy. I think there is some recommendation from NICE about it.
Yeah, that's what I said, like prostate more than 30 cc, increased PVR. There is a list which we gone through. Yeah.
I think it's the same thing from the Olmsted County. Pretty much, they've copied pasted it. It's a PSA more than 1.4, prostate volume more than 30 cc. It's like that.
Yeah. So the Olmsted County is more of BPH progression study. It found these features will make the prostate to progress quickly. these are all like high risk factors, and NICE recognize these factors and said that okay, if there are any high risk factors which may make this BPH to progress faster, why to just treat with only one drug, tamsulosin or alfuzosin, which is not a prostate constricting drug. It's only going to relax the blockers, which results in a bit of a stability. Why can't we add the 5-alpha reductase inhibitors so that the prostate shrinkage also happens, so that we know the patient is going to fare worse, and these are the patients who may require surgery quite early. Okay.